All right, this is Elias Hanna. I am going to give you a talk about antiplatelet therapy, acutely and long term. This talk has a lot of references to a lot of studies, but the way I do it, I try to keep it practical. So I try not to elaborate on any trial. I will mention a lot of trial names, but I will mainly give you bottom lines, okay? I will start by talking a little bit about pharmacology, about antiplatelet agents, and then I will dive more into clinical aspects throughout the talk. That includes also combinations in various settings, such as stable CAD, non-STEMI, and STEMI. So this is a basic slide. There are four main receptors that are involved clinically, four main platelet receptors that are relevant to us clinically. The more important bottom line receptor, which is a final common pathway for platelet aggregation, is the 2B3EA receptor that you see here. This allows a cross-linking of platelets via fibrinogen molecules. All the other receptors that we work on clinically actually serve to activate and create conformational activation of that receptor. The three other receptors relevant clinically, you have the thromboxane A2 receptor, which is on which aspirin works via the COX-1 inhibition. You have the P2Y12 ADP receptor, and you have the thrombin receptor. There are multiple ADP receptors, but this is the most important one, the P2Y12. ADP, again, is a platelet activator that leads to activation of 2B3A receptors. We have multiple clinically relevant ADP receptor activator. We have the Clopidogrel and prasugrel that are prodrugs that get metabolized into a metabolite. They have the same metabolite, both of them, and that metabolite activates the ADP. You have Ticagrelor and the intravenous Cangrelor, both of which bind directly to the ADP receptor. They do not need bioactivation. The third receptor that we don't often talk about is thrombin. It's a very potent, actually, receptor for platelet activation. Clinically, there is one oral drug, Vorapaxar. It's FDA approved. It's been FDA approved for many years. It can be used chronically beyond a year of MI as an alternative to ADP receptor antagonist. We don't often use it, so I'm not going to elaborate much on it. Just know that it exists. So I'm going to start talking about the ADP receptor antagonist. I noticed that fellows don't know the properties of those antiplatelet agents very well. So I want you to know the pharmacodynamic and pharmacokinetic properties of those agents that we use every single day. I will also elaborate in a little bit about how to switch between those, using those pharmacokinetic properties. So one, Plavix, and I will mention trials, I won't elaborate, but the landmark trials of Plavix are CURE trial for non-ST-ACS and COMET trial for STEMI. Those are all trials, CURE trial in 2002. So Plavix or Clopidogrel, it started. So when we use the loading dose of 600 milligram, you need to know that you achieve the effect at about 2 to 4 hours. It starts minimally at 30 minutes, but it really becomes clinically relevant and nearly optimal at 2 to 4 hours. You need to remember that number. It achieves 35% inhibition of platelet aggregation in the best case scenario. Keep that number in mind. Now, on the other hand, if you load with a 300 milligram, the effect starts around 24 hours. So it's not suitable for when you're doing your procedure in a few hours, or if you've already done your procedures. You can do it if you're doing an elective PCI. You can ask the patient to take 300 milligram the morning before your procedure. This is where 300 milligram is relevant. Or if you're loading an ACS patient, again, on admission before several hours, many hours or a day before a procedure. 75 milligrams take 3 to 7 days to kick in its effect. So also, if you're doing an elective PCI, you can ask the patient to start 75 milligram daily a week before, but that's not suitable for us in the acute setting. So remember those timelines. Another idea about Plavix, and this is where the 35% number enters as compared to the subsequent numbers I will describe with prasugrel and others. Clopidogrel is bioactivated into an active metabolite similar to prasugrel. And it's bioactivated via multiple cytochromes, but the main one is that cytochrome P2C19, the famous one. Now, only 15% of clopidogrel is activated and 85% is degraded by esterase. So depending on the patient's gene variant of CYP2C19, if he has a mutant of that heterozygote or worse, homozygote mutant of the CYP2C19 that make it less active or inactive, clopidogrel will be diverted fully into basically trash. So it will not go into an active metabolite. And this explains why clopidogrel is not a very potent antiplatelet agent, and two, why there is a lot of variability in the potency of clopidogrel. It's not always 35% platelet inhibition. That's what you shoot for. But in about 30% of patients, those with a mutant of CYP2C19, they will have hypo-responsiveness, which could be mild or it could be severe, depending on what mutant and whether they are homo or heterozygote. So Plavix resistance, what we call, or hyperresponsiveness, is seen in 30% of patients. And in this case, they will have significantly less than 30% of platelet activation. On the other hand, prasugrel, which gives the same active metabolite and use the same cytochromes, does not have a diverting pathway into esterases. Therefore, even if you have a mutant of those cytochromes, prasugrel has no other way out. So it will be metabolized into active metabolite, albeit maybe more slowly, but it will get metabolized. That's why you don't get prasugrel resistance. You do get Plavix resistance. So know those ideas. So I mentioned prasugrel. So realize that prasugrel is stronger and more potent and more consistent platelet inhibition, as opposed to the 35% with the Plavix. We have about 70 to 80% with the prasugrel. Onset of action is already at 30 minutes. It gives meaningful platelet inhibition, but it reaches that 70-80% at 2 to 4 hours. So it also takes 2 to 4 hours to reach the optimal effect, except being so potent, you already get a significant platelet inhibition, maybe 30+% by 30 minutes. Like Plavix, it's an irreversible, or its metabolite, the same metabolite, it's an irreversible ADP receptor antagonist. The landmark trial is a Triton TIMI-38 trial. In that trial, it reduced, compared to Plavix in STEMI and non-STEMI patient, it reduced a composite endpoint compared to Plavix. It did not reduce mortality, keep that in mind, very important. And it did increase TIMI major bleeding, which is difficult to meet. That's really the ultimate major bleed, TIMI major bleeding. It's the most difficult definition for major bleeding. It did increase TIMI major bleeding, and it did increase fatal bleeding, which is very rare actually in any antiplatelet trial. Keep those ideas in mind. No mortality difference, but reduction in a bunch of other, ischemic endpoints, mainly MI and stent thrombosis. The main thing in Triton is that patients who have the highest bleeding risk and the least benefit from it, least net benefit from it, were prior history of stroke or TIA. That's why this is an absolute contraindication to prasugrel. You should always ask that question before giving prasugrel. Weight less than 60, age over 75. Those are relative contraindication. Guidelines allow you to use those, to use prasugrel in those, but half dose instead of 10 milligram, 5 milligram maintenance. Prasugrel is also started like Plavix, a load of 60 milligram, then a maintenance of 10 milligrams, except in those two groups, the age and the weight, you can use the 5 milligram. or you should use the 5 milligram. So several points about prasugrel and the Triton trial. It's only studied in ACS patient undergoing PCI. So this is not for stable CAD PCI, and this is not for ACS treated medically. In fact, prasugrel has failed to show any benefit in another trial of ACS patient treated medically. Unlike Plavix, which can be used and has shown benefit in cure sub-study in ACS patient treated medically, that's not the case with prasugrel. Another thing, while Plavix may be used upstream of catheterization before you do the cath, prasugrel should not be used before coronary angiogram, before seeing the coronary anatomy, by guidelines and by design of the Triton trial. Actually, if given and the patient has to wait for CABG at least 7 days, and if you have to undergo CABG within 7 days, the bleeding risk is 4.5 times higher. The surgical bleeding risk is 4.5 times higher. Keep in mind that Plavix already increases surgical bleeding risk by around 4%. So this one is 4 times higher on top of Plavix. So keep that in mind. You have to make sure he's not going to undergo CABG before giving that. The only exception is a STEMI. You can give it before cath if you're certain the patient has a STEMI, just because there's a very low chance of those going to CABG, less than 1%. Now, like I mentioned, this prasugrel has caveat and has risk and no mortality difference. So there are subgroups that benefit more, where you may feel more compelled to use it. And in the sub-studies, a STEMI patient, particularly anterior STEMI, that's the only subgroup that seemed to derive a mortality benefit. Diabetes and those patients with recurrent events while on Plavix. In those groups, the benefit way more outweighed the bleeding risk in those subgroups. And there was, again, possibly trend toward mortality improvement in diabetes and in the anterior STEMI. Another idea that's important, in my opinion, not much talked about, is that a landmark analysis of Triton shows that most of the benefit is in that first 30 days. You continue to have benefit beyond 30 days compared to Plavix, but the biggest benefit is in that first 30 days. And that will come later when I talk about possibly de-escalating your treatment at 30 days. So I'm going to talk about Ticagrelor now. So I mentioned prasugrel and Clopidogrel. I'm going to talk about Ticagrelor, which is more widely used. Although it's really not better than prasugrel. I will mention it a little later. So Ticagrelor, the main trial is a Plato trial. So Ticagrelor is, unlike prasugrel and Clopidogrel, is an irreversible ADP receptor antagonist. Prasugrel and Clopidogrel metabolite binds to the ADP receptor and inhibits it irreversibly for the life of the platelet. Ticagrelor, on the other hand, is a reversible receptor antagonist. And so it binds off and on. And it works directly on the ADP receptor. It doesn't need a metabolite, although it does also have an active metabolite, but it doesn't need it. It acts directly as well before it gets metabolized. The interesting thing is that it has a total half-life of 15 hours. I'll go back to this. You will keep in mind this to realize what's the duration of effect of Ticagrelor. It's a different chemical agent. It's not a thionopyridine. It's different from prasugrel and Clopidogrel. Almost similar in that property, in a sense that it's similar to prasugrel in that property, in a sense that it inhibits platelet almost as fast in 30 minutes and as strongly as prasugrel. Again, it reaches the peak effect around 2 to 4 hours. So 30 minutes, 2 to 4 hours, and 70 to 80% platelet inhibition. It also has other properties. It binds to non-platelet P2Y12 receptors, so it has some vasodilatory effect. It blocks adenosine reuptake by red blood cells, so it has some adenosine effect. You'll hear that. That could be a contributor to the dyspnea that you get with up to 5% of patients with ticagrelor. In some real-world registries, up to 10% of ticagrelor treated patient gets some dyspnea, subjective dyspnea, not objective, but it's attributed to that adenosine effect. Although they extremely rarely get bronchospasm, it's mostly just subjective dyspnea. All right. So what happened? What did ticagrelor achieve in the Plato trial? It reduced ischemic events similarly to prasugrel by about 2% compared to Plavix. This is on comparison with the Plavix, not with placebo. Importantly, it reduced mortality by 1%, but it did reduce mortality, which is also rare in those antiplatelet trials, and this is a difference compared to prasugrel. Prasugrel, again, did not reduce mortality. Another interesting thing is that it achieved that in all ACS patients. Unlike prasugrel, which is only studied in patients undergoing PCI, ticagrelor achieved this benefit in all ACS patients, and the trial included all ACS patients, meaning non-STEMI, STEMI, but the non-invasively managed non-STEMI as well. There was definitely an increased bleeding signal, although it sounded a bit different than prasugrel, but in reality, it's, in my opinion, the same thing. It does increase bleeding risk probably similarly to prasugrel, although there were no specific subgroups of harm, such as the prior stroke, the age, and the low weight. Those did not seem to be excessively harmed by ticagrelor. And therefore, those are not contraindication to ticagrelor. So prior stroke is not a contraindication, although I will advise cautiousness here because I think it does increase bleeding risk as much as prasugrel, at least. But no specific contraindication as far as subgroups. Another interesting thing here, again, ticagrelor was studied in non-invasively managed non-STEMI as within the Plato trial, and there was actually a very dramatic benefit in that subgroup. So keep in mind, we can use it in medically treated non-STEMI, even though, and maybe because those patients had more comorbidity, they derived even a more dramatic benefit with ticagrelor, including a mortality benefit. That's interesting compared to prasugrel, which again is not studied in this population. Also, it's the only ADP antagonist of which the benefit was not reduced in CKD. Both prasugrel and clopidogrel's benefit is reduced and attenuated in CKD. Ticagrelor, on the other hand, the benefit of it is similar in CKD and non-CKD patients based on sub-studies of Triton. Now, interesting, it does seem, based on what I'm mentioning, that ticagrelor is maybe the more interesting drug compared to prasugrel, if you want to choose one of the potent ones. That has been the attitude for 10 years. But one has to keep in mind different trial designs. So when those two drugs were compared head-to-head in the ESA React 5 last year, or a year and a half ago, interestingly, prasugrel was the superior drug. And ESA React 5 was a study comparing prasugrel versus ticagrelor in either non-STEMI or STEMI. Almost half were non-STEMI, half were STEMI. It was a complex trial because they compared upstream ticagrelor before cath to prasugrel during cath. So the timing of use of those drugs was different, and that may have contributed to the difference in outcomes. Maybe upstream use of drugs is harmful, and that was a contributor to the harm with ticagrelor. It's possible. But nonetheless, this upstream ticagrelor versus downstream prasugrel, in that study, prasugrel was superior on the primary outcome of MI death, 9.3 versus 6.9%, almost 2.5% reduction with prasugrel. There was no difference in bleeding. Actually, numerically, the bleeding risk was higher with ticagrelor. It was not statistically significant. So keep in mind, Ticagrelor is not superior to prasugrel. I know we don't use here prasugrel a lot in our institution, and across the US, it's not the very popular one, but it's probably the superior one if you want to use a potent antiplatelet agent, if you don't want to use Clopidogrel. Now, what are the guidelines tell us? Let's take patient with ACS, non-STEMI or STEMI. Should we use Clopidogrel or should we use prasugrel or Ticagrelor? Should we use the more potent antiplatelet agent based on guidelines? So even in the 2014 ACS guidelines, they give those are the ACC guidelines. They give a class 2A preference to using one of those two, Ticagrelor or prasugrel. Again, prasugrel only if the patient undergoes PCI, Ticagrelor whether he undergoes PCI or not. They give a preference, a class 2A preference to those as opposed to Clopidogrel. So they do want you to use them. Even worse, the ESC guidelines, including the newly published and updated guidelines in 2020, they give a class 1 recommendation for prasugrel and Ticagrelor over Clopidogrel. Look what they state. Clopidogrel is only used when prasugrel or Ticagrelor are not available, cannot be tolerated, or are contraindicated. So they do not want you to use Clopidogrel in ACS, STEMI or non-STEMI. They want you to use the other two unless there is a specific contraindication. So they are quite aggressive in that regard. Furthermore, the European guidelines based on that ESA React 5 trial, they actually give a class 2A preference to prasugrel as opposed to Ticagrelor. So they prefer prasugrel. So keep those ideas in mind. But what do I think actually, looking at the data? Should we use really Ticagrelor or prasugrel in all ACS undergoing PCI? Yes, per data and guidelines, but there are huge caveats, and I'm going to go over them. One, I think those should be considered more readily rather than using them uniformly in all ACS patients. They should be considered more readily in the high-risk subgroups, STEMI, diabetes, recurrent event, multiple complex procedure, and low bleeding risk subgroups. So you combine ischemic with the bleeding risk. That's one. Keep in mind, again, they are not studied in stable CAD. I will keep repeating that. Even if you do complex stable CAD, you may choose to use prasugrel or Ticagrelor, and some interventionists do. Just know this is off-label and this is off guidelines. Complex left main, stable CAD is not an indication for any of those two. It's just Plavix. So the reason I'm not super excited about those agents, unlike the guidelines, is that you always have to weigh your risk and benefit. So there are one interesting trial of last year that randomized patient to Plavix versus Ticagrelor in patients older than 70. It's called Popular Age Trial. Interestingly, there was no benefit of Ticagrelor in patients over the age of 70. There were just more bleeding, but same MACE, ischemic event, and mortality. The very large Swedish registry has shown also in patients over the age of 80, there was a signal of increased mortality with Ticagrelor and bleeding. There was a benefit in less than 80. So keep age in mind, over 70, definitely over 80. I'm extremely careful about using those drugs. Another strategy that I may use and that is reasonable is, well, okay, maybe I would start it and use it for a month, then consider de-escalation after 1 month, since the benefit seems to be highest in that highest risk period, which is the first month. And there was a trial in 2017 that addressed that systematic de-escalation at 1 month from prasugrel, Ticagrelor to Clopidogrel. It showed actually there was no harm in this de-escalation. There was the same ischemic, the same number of ischemic events, and you reduce bleeding dramatically by just de-escalating at 1 month. Rather than giving them for a year, you give them for 1 month, and you switch at 1 month to Clopidogrel. There was dramatic reduction in bleeding by doing so with no harm on ischemic events. Even the TIMI bleeding risk was reduced almost 3 times. So keep that in mind. Another thing that one may think of is, well, maybe I should look whether Plavix whether we're resistant to Plavix or not, and tailor its use accordingly, tailor the use of the more potent drugs accordingly. That seems like a reasonable strategy, except it's not proven to be useful, and I'll go over that a little later when I talk about platelet reactivity quickly. And there is one trial that tailored PCI that included mostly ACS patients, published last year in JAMA, and it tried to use genetic testing to decide whether I put the patient on Plavix or Ticagrelor, again, mostly ACS setting. And that trial failed to show a benefit of using that strategy. And actually, the universal use of Plavix in that trial was as good as using Ticagrelor tailored to genetic testing. So while you may use platelet reactivity or genetic testing to decide about the other agents, keep in mind that has not been proven in a randomized fashion. Although it is reasonable, it's not proven. I think what has been proven in a randomized fashion is if you start somebody on Ticagrelor and prasugrel and you want to de-escalate at 1 month, you can choose to de-escalate to Plavix at 1 month systematically, as I mentioned here. But what is maybe better and what has been proven in 2 trials is that platelet reactivity testing is most useful to de-escalate. It's not very useful, it seems, to decide about escalating, but it helps you be more comfortable de-escalating from the potent one to Clopidogrel at 1 month. Meaning, if you're not platelet resistant, if you're not Clopidogrel resistant, at 1 month, you downgrade, to Clopidogrel or to Clopidogrel, you achieve the same ischemic events at 1 year and significantly less bleeding risk. So genetic and platelet reactivity testing can be used for de-escalation at 1 month. And those are given class 2 in the European guideline. Again, not widely adopted, but all those are fairly recent data. All those are in the last 2 years. So again, in my opinion, I don't use them systematically. Keep in mind, compared to Clopidogrel, take into account the age, the older than 70, 80, and more questionable net benefit of those agents. Take into account the presentation, STEMI, diabetes, multiple recurrent ACS. Those are the patients who probably do benefit from the more potent antiplatelet agents. Also keep in mind the idea of de-escalation and potentially using genetic or platelet reactivity testing to de-escalate, especially to de-escalate at 1 month. But you can do de-escalation even without those. And that's probably the more practical approach. I want to mention an important idea to me, which is, and that will help us understand what we call the switch between those antiplatelet agents. What is the difference between pharmacokinetics and duration of effect? So I'll ask a basic question here, and I will answer it, but I do want fellows to think about it. And if somebody wants to answer it, would be good. What is aspirin's half-life? We use aspirin 50 times a day. Can any fellow tell me what's the half-life of aspirin? Same with the other ones. What are the half-lives of the other one? Anybody has an answer? All right, well, I will answer it. Unlike what a lot of people think, most people, when I ask them what's the half-life of aspirin, they tell me, I don't know, 5 days, 7 days. That's incorrect. The half-life of aspirin is only half an hour, actually. But, and this is the difference between half-life and duration of effect. Aspirin, the half-life is only 30 minutes, but the effect is 5 to 7 days, simply because it binds irreversibly to the thromboxane A2 receptor. So, to the cyclooxygenase 1. So basically, it comes in, it gets eliminated from the blood quickly, but in the process, it binds irreversibly to those receptors and it stays there for the life of the platelet. Same with Clopidogrel and prasugrel. Both those have short half-life of only few hours, but their duration of effect is 5 to 7 days. The converse happens with Ticagrelor. Ticagrelor is not an irreversible binder. Yet, it has a long half-life. So even though it's not an irreversible binder, the relatively long half-life compared to the other one makes it act for about 3 to 4 days. Okay, you understand that nuance? It's extremely important. I'll elaborate in a minute. But that allows you to understand how to switch between those drugs. So again, 5 to 7 days, aspirin, Plavix, and prasugrel. Ticagrelor, 3 to 4 days. Again, that helps you decide about when to stop before a procedure as well. Now, there is one drug along those lines. I'm going to describe a drug, Cangrelor, which is intravenous ADP receptor antagonist, which, unlike those, it has a short half-life, very short half-life, but also a very short duration of effect, because it's unlike Ticagrelor, it has a very short half-life, it's reversible with a very short half-life, and that translates into very short duration of effect. So Cangrelor, it's a very potent ADP antagonist. It binds directly to the ADP receptor. It achieves 90% platelet inhibition, more than Ticagrelor and prasugrel, which achieve 70 to 80%. It is reversible, like Ticagrelor, but unlike Ticagrelor, it has a very short half-life. This translates into very short off and on effect. It is useful. Now, where is it used? This is not a drug to be used as bailout if you're having a complication. This is a drug that is only valuable if a patient has not been on ADP receptor antagonist before your procedure, and you want to use something potent, you're doing complicated procedure, you want to be covered during your procedure. Because remember, the other one, they take 2 hours, they kick in within half an hour, the potent, Ticagrelor or prasugrel, but they don't achieve a good effect until 2 to 4 hours later. So you want something potent during your procedure. This is when you use Cangrelor. And the beauty, you turn it off, within half an hour, it's gone from your system, okay? So Cangrelor is useful in patients who have not been preloaded with ADP receptor antagonists. That's the only case you can use it. You cannot use it if somebody has taken Plavix, prasugrel, or Ticagrelor. They have to be what you call ADP receptor naive. So it is useful only during PCI, stable or ACS, but more likely, and this is given in class 2B, but more likely in ACS and rather complex PCI. The way you use it, you start it during PCI, you have to give it for at least 2 hours and at least the duration of PCI, whichever is longer. It's been shown in the 3 champion trials, especially champion Phoenix trial. It's been shown to reduce stent thrombosis and procedural complications. It increases minor bleeding. Again, no effect on mortality. Okay, so again, we might use it more so in ACS, although it's been studied in stable CAD in the champion trials. Champion Phoenix included stable CAD, but probably more so geared to ACS, not preloaded, and it's a complex PCI. You do want immediate antiplatelet action. It may be particularly useful in shock states where the absorption of oral agent is limited, and high-risk PCI in the setting of ACS, as I mentioned. Now, this is a difficult question with Cangrelor. I think it's reasonable to use Cangrelor, and you will be seeing it in our cath lab. Now, the biggest question is how to switch, because by definition, you're using it in patients who are not receiving ADP receptor antagonists, oral ADP receptor antagonists. So you infuse it for the duration of PCI and at least 2 hours. Now, how to switch to the other one? And this is where pharmacokinetics are valuable. You cannot give, unfortunately, Plavix and prasugrel while the infusion is running. The idea is their half-life, the metabolites half-life of those is very short. So by the way, if you give Plavix or prasugrel and Cangrelor is running, that metabolite is not going to be able to bind to the ADP receptor, okay? And since it has a short half-life, by the time you stop your Cangrelor infusion, that metabolite is already gone from your blood. So there is a concern if you give Plavix and prasugrel during Cangrelor infusion, you're not going to have any effect of it. The load will be wasted, and you might increase the thrombotic event. So the idea is that with Plavix and prasugrel, you have to wait to the end of the infusion, then give your load, okay? With prasugrel, you can give it half an hour before, but you cannot give it during the infusion for that pharmacokinetics idea, okay? Ticagrelor, on the other hand, just because it has significantly longer half-life, even if you give it during the infusion, it's enough of it will be hanging around by the end of the Cangrelor infusion that it's okay to give Ticagrelor while Cangrelor is running. Again, because of it has a longer half-life. It's going to stick around for a lot longer and still be able to bind to ADP receptor several hours later. That's the main explanation I found. That's the consensus explanation. It's based purely on half-life. That's the international consensus explanation. There are some explanations that Ticagrelor binds to a different P2Y12 site, different than Cangrelor, but that's more debatable. So the main explanation is half-life. I hope everybody understood. Actually, it's the same idea, just quickly, that explains why if somebody takes aspirin and is taking ibuprofen, well, if he needs to take ibuprofen, at least he should not take ibuprofen before he takes aspirin. If you take ibuprofen, then an hour or half an hour later you take aspirin, aspirin is going to be ineffective just because ibuprofen is bound to the COX-1, okay? And when aspirin comes in, it's not going to be able to bind because ibuprofen is bound to it. And when ibuprofen is gone from your system, well, aspirin is already gone from your system because the half-life is only half an hour. So keep those ideas in mind, okay? So now how to switch. So I mentioned how to switch from Cangrelor to Plavix, prasugrel, and Ticagrelor. Now, maybe even a more important question, how to switch from Ticagrelor to Plavix and how to switch from prasugrel to Plavix. It is also a difficult idea because, again, if you give Plavix simultaneously to Ticagrelor or just an hour after giving Ticagrelor, well, it may not be able to bind because those receptors are loaded by Ticagrelor. At the same time, you cannot wait 4 days. You know, if you want to switch from Ticagrelor to Plavix, you cannot tell the patient, well, let's not take anything for 4 days and I'm going to give you Plavix in 4 days. Of course, you're not going to do that either. So the consensus, and this is based on international consensus, is that to switch from Ticagrelor to Plavix, wait a day, 24 hours. So you give Ticagrelor this morning, you don't give anything the rest of the day, even though Ticagrelor is twice a day, but you don't give it today anymore. And you give Plavix load 600 milligram tomorrow morning. The idea is that by that time, you know, some of that Ticagrelor has gone out of the platelet receptor and some new platelets have formed in a way that the 600 milligram is more likely to bind and be efficient. The same idea applies to switching from prasugrel to Clopidogrel. Wait 24 hours and next day you load with 600 milligrams. Now, on the other hand, if you're switching from Plavix to Ticagrelor or prasugrel, you don't need to do that. You can load immediately with the other agent. So, for example, if the ER has given the patient Plavix load, or on the floor in ACS they have given the patient Plavix load, and you want to give them Brilinta, you can immediately decide to give the patient Brilinta, even though he took the Plavix load 2 hours or an hour before. You can immediately load them on the table with Brilinta or prasugrel. So from Clopidogrel to the more potent agent, you can reload immediately. More potent to Plavix, it's a 24 hours, and you have to use 600 milligram of Plavix. The idea here simply is that Plavix doesn't overload those receptors. It only inhibits 30% of them. So when you give Ticagrelor or prasugrel, they have way more than enough receptors to bind to and remain effective. This is based also on international consensus guidelines published in Circulation. Now, I want to switch to another clinically relevant idea. Should you preload with ADP receptor antagonist or not? Let's say you have somebody coming with non-STEMI. What I see a lot of doctors do, they give, and we used to do that based on the CURE trial, is that they give systematically everybody Plavix before knowing the coronary anatomy. Now, and if you do that, you will give 300 milligram, not 600 milligram, based on based on the CURE trial, okay? And you can give the extra 300 milligram of the cath lab. But this is an outdated practice. Based on two major trial and one major registry, preloading versus waiting to load in the cath lab, it has not shown any benefit. Actually, it has shown harm. You get more bleeding risk by preloading than by waiting to downstream loading in the cath lab. There are two main caveats of those trials. They use the potent antiplatelet inhibitor that work quickly if you load them in the cath lab. That's one. Two, they took the patient to the cath lab very quickly, within a few hours, 4 hours on average, 4 to 5 hours after presentation. So you may think that that idea, the preloading, may still be relevant in patients who are undergoing cath 3 days later. But this is not common practice. I think in the modern era where the patient undergo cath within 24 hours and where we more readily use potent agent, preloading is not relevant. It's actually harmful. So much so that European guidelines actually give it class 3. Basically, they contraindicate preloading in non-STEMI. It's contraindicated to preload based on the 2020 European guidelines. Myself, I haven't adopted the systematic preloading strategy since 2014 when a cost trial got published. Interestingly, the SCAR registry was, half of it was Plavix, and the delay to cath was almost 2 days. But even despite that, there was no benefit of preloading. So that supports what we, that goes against what we do. Even with delays to cath, with using Plavix, no benefit of preloading. So I hope at least if you get, one of the things you get from this is that preload patients less in ACS. It's outdated practice. Definitely do not preload those who seem to have high risk of undergoing CABG, extensive ST depression in more than 6 lead, or ST elevation in AVR. So in STEMI, preloading is still reasonable. Both the ACC and ESC suggest you're allowed to preload in STEMI just because very few patients undergo CABG, and because platelets are much more active in STEMI, it's reasonable to preload and get some of the effect during your PCI. But they don't, they give you the option before or at the time of PCI. ESC for STEMI favors preload. That's the only subset it favors preload. Keep in mind, there is one trial of preload in STEMI. It's called Atlantic trial. It showed no benefit of preload even in STEMI. Actually, there was an increase in mortality somehow that's difficult to explain. So questionable even in STEMI, but favored. Although, again, even in STEMI, it is questionable. So you don't even have to preload. The most important idea in STEMI is do not preload if you're not absolutely certain of STEMI diagnosis. And that's the reason why on a policy basis, I discourage emergency doctor from preloading STEMI simply because half the time they miss the diagnosis. Then they give Brilinta to somebody who doesn't have a STEMI, and they will aggravate his situation. Now, in stable chest pain, undergoing angio, we definitely don't preload. If you do cath and you find that he needs an intervention, we give ad hoc Plavix during the case or at the end of it. That was also proven in several trials. I don't have a lot of time left, but I do want to discuss this important topic of duration of dual antiplatelet therapy. That's a totally different topic. So we talked mostly acute. Now, chronic, what's the duration? The standard duration of dual antiplatelet therapy in ACS is 12 months. But how about more than 12 months? Is there data for more than 12 months? How about less than 12 months? So there are two sets of data for those two instances. Okay, the center being 12 months. Those are my summary of the guidelines. The guidelines kind of complicate them, but this is the bottom line slide that you need to know. This is the guideline slides. So you undergo stent with DES. If it is in the stable CAD setting, the recommendation for DAP, the class 1 recommendation, is 6 months, by the way. I hope everybody knows it's not 12 months anymore for stable CAD. It's 6 months. And it's only Plavix, not the other two, as I mentioned, in stable CAD. So class 1 for 6 months. It's okay to stop at 3 months if you have high bleeding risk, class 2B. Now, if you're ACS, STEMI or non-STEMI, the class 1 recommendation is for 12 months of either of those three. And as I mentioned, they give preference to prasugrel or ticagrelor. Then the question is, you can do less than 12 months, you can do 6 months if high bleeding risk or need for surgery, but they give that class 2B. Okay, so basically, stable CAD, the default is 6 months, 3 months, okay, if needed. In ACS, 12 months, and 6 months is okay if needed. And actually, 3 months is okay for surgery. Again, class 2B, only for surgery, brief interruption, temporary interruption, class 2B. Now, they also give, similarly, class 2B for extending it. So class 2B for less, but also class 2B for more than 6 months in stable CAD and more than 12 months in unstable CAD. Okay. The recommendation also, if you don't undergo PCI, maybe that's less important column. The recommendation is for 12 months, but you can do more than 12 months if, again, same idea, a bleeding risk profile favorable, also class 2B. And as I mentioned, surgery in all settings, they allow you to interrupt at 6 months in all settings, class 1, at 3 months, even after ACS, class 2B. Okay, so surgery, you kind of apply almost the stable CAD to ACS. It's 6 months, you can interrupt on everybody, class 1, 3 months in the, you know, if you have to, class 2B. So I hope everybody understands that slide. I'll send it to you. It's an extremely important slide. Now, what's the background for those? Okay. So there is this study called DAPT trial. I hope you all know it, landmark trial. So what it did, it randomized patient to 1 year of DAPT versus stopping DAPT at 1 year versus continuing it to 2.5 years. And what that DAPT trial showed is that continuing it for an extra 1.5 years, it reduced MI in half from 4 to 2% in that period, 1 to 2.5 years, by reducing, remember, stent thrombosis, but also distant MI from distant lesion, which account for half of actually the long-term event. So you don't just think of the stent, think of other lesions, which are responsible for 50% of long-term events. So it reduced that, but interestingly, it increases bleeding as you expect. It increases cancer death and overall death related to cancer and bleeding. It was significant. P was 0.05, barely significant, but significant. The investigator tried to dismiss that, but I would not, because actually this has been shown over and over. Long-term DAPT reduces your MI risk, but it does increase your non-cardiac mortality and your major bleeding. It does increase mortality too. There is this signal, still controversial, but I do believe in it. There is this signal. It does increase mortality. So it's okay to use it, but you have to fine-tune your risk-benefit evaluation. And how do you fine-tune it? So this is the class 2B here, more than 12 months or more than 6 months. The class 2B, how do you decide to go that and not expose the patient to an increased bleeding and or death risk? And this is where we use 2 sets of scores. One is the DAPT score, which is derived from the DAPT study, and they try to fine-tune which patients derive an MI benefit without much of a bleeding and death harm. So this is a DAPT score, mostly a clinical score. Then you have an anatomical score that I will go over. DAPT score, just, you know, look at it. Basically, the DAPT score, I will highlight age. The older you are, over 65, especially over 75, the less you need to be on DAPT. The less they favor long-term DAPT, the more you're hurt from death and bleeding standpoint. So you try to stop it at 1 year in those patients. The more you have of those other one, ACS at baseline as opposed to stable CAD, prior event, smoking, diabetes, heart failure, especially heart failure is a big one. Heart failure patients have more long-term stent thrombosis and coronary event, ischemic heart failure. So those patients, you do favor longer DAPT. You calculate the score. If it is over 2, you favor long-term DAPT. So, but again, I want to remember, we see patients who've had a stent 5 years ago and they are still on Plavix. We keep them on in our clinic. Keep in mind, it's not a slam dunk. I mean, there was a signal of increased mortality by keeping those patients on for over a year. So always balance risk benefit, okay? Ask yourself, should I really keep him for more than a year? So, and this is a study that proved the anatomical complexity. And those are the 6 features that constitute anatomical complexity. If you have one, but especially if you have 3 of those, you favor long-term DAPT. So those are the 6. Is the 3. Remember that 3 number. 3 vessel treated, 3 stented, 3 lesions treated, bifurcation, stent length more than 60 millimeter or CTO. If you have one of those, you derive a more dramatic benefit of DAPT than if you have none. If you have none, there was no benefit of long-term DAPT. The more you have, if you have more than 3 of those, the worse it is. But at least one favors DAPT. Now, how about, that's an even a more interesting idea. How about shorter DAPT? Okay, now I talked about, so again, 12 months is our background in ACS, 6 months in stable CD. I talked which patient can go beyond. Now, how about going less than 12 months or 6 months? There is a lot of data out there, including those 4 randomized trials, showing that 3 months can be as good as 12 months, actually. So going less, 3 months is as good as 12, based on those 4 randomized trials. 2 of them use Ticagrelor, and that makes sense that 3 months of Ticagrelor, if you're using beyond that, you're using between 3 and 12 months, you're using Ticagrelor, it makes sense that single antiplatelet therapy may work just because you're using a potent one. But 2 of them used 3 months of DAPT followed by Clopidogrel monotherapy, and they did show similar ischemic events, lower bleeding outcomes. So 3 months in some patients might be acceptable, lower risk patients, maybe even lower risk MI potentially. 3 months is acceptable based on those data. The more important data I want to go over, though, is this. So those trials are, interestingly, those 4 were designed comparing 3 months DAPT versus 12 months DAPT. But you have another 3 sets of trials that compared 1 month DAPT with DES versus BMS. So they did not compare 1 month versus 12 months. They did compare 1 month DAPT with DES versus bare metal stent. And notice I haven't mentioned bare metal stent in the whole talk. I haven't used bare metal stent in 8 years. They are outdated. I don't even know why books still mention them. I mean, they really have absolutely no role in our current practice, in my opinion. I don't think we should use them. And those studies prove that. People think bare metal stent are safer. They are absolutely not safer. This was shown in the DAPT sub-studies. It's not safer. You have the same risk of stent thrombosis with BMS versus DES. Actually, maybe a little higher with BMS. And those studies show that. So those studies compared, we think 1 month with BMS is safe. Okay, that's in the guidelines. Well, guess what? They compared 1 month of DAPT with BMS versus DES, the modern 2nd and 3rd generation DES. Synergy, stent in the senior trial, and Resolute in the Zeus trial. What basically, this is another stent, Leaders Free trial, European stent. But basically, with 1 month of DAPT, and they included some ACS patients, not a lot, but they did include, especially the Zeus trial, 50% MI. Basically, you have the same events after stopping DAPT at 1 month with BMS versus DS. Actually, you had more stent thrombosis with bare metal stent. And meta-analysis of those 3 trials showed that DS was actually superior to BMS when you only use 1 month of DAPT with less MI and less stent thrombosis. The idea here, I want to say this. This is not in the guidelines yet. And I'm not suggesting you should ask patients to stop at 1 month. We still have to use at least 6 month ACS, at least 3 months in stable CAD. And you can use a 3 month, as I mentioned, for patients who need to interrupt for surgery, even if they are ACS, and with drug-eluting stent, as I mentioned here. So this is what we should follow, basically at least a 3 month if you're going for surgery. But this gives you an idea that don't think putting a bare metal stent allows you to stop DAPT sooner. It may allow you medico-legally, it may allow you by guidelines, but consciously just realize you're not really helping the patient by putting DIS and stopping at BMS and stopping at 1 month. Data shows that makes no difference. I don't think BMS should be used. Now, this is from the European Guidelines 2020. So what you can see, this is the only guideline that has ever recommended in a class 2A or that has ever agreed to use in the setting of ACS, drug-eluting stent. If you have high bleeding risk, they were okay with using dual antiplatelet therapy for 3 months only. If you have very high bleeding risk, and there are bleeding risk scores, you can use it actually 1 month. They give a class 2A to use dual antiplatelet therapy for 1 month only in ACS, DES, in the ESC guidelines. So this is very new, and it's based on those few trials I mentioned before. I guess I'm done. I understand you have to go. For those who can stay, I can stay for 3-4 minutes to mention this important idea here, just to finish the talk, is that I'm switching gears here. I'm talking about patient now who needs anticoagulation, such as patient with AFib or LV thrombus or prior PE. So they receive a stent and they need a chronic anticoagulation. So I will just give you the bottom line. There are 5 trials that assess that. All 5 trials have shown the following. The default strategy is that you do the stent, you give them triple therapy during the hospitalization, aspirin, Plavix, and 1 anticoagulant. Then you discharge them home on only Plavix and 1 oral anticoagulant. No aspirin. The aspirin is only used during the hospital around the procedure for a total duration of 1 day to 1 week in those trials. So it's this default strategy is dual therapy. Now, based on sub-study of Augustus trial, patients who have a high ischemic risk, such as the non-STEMI patient, or the MI patient in general, who also have additional ischemic risk factor, such as coronary complexity. So high ischemic risk and low bleeding risk, those patients are probably served by taking triple therapy for 1 month, then you stop aspirin at 1 month and continue with double therapy. You should not ever use triple therapy for more than 1 month. Keep that idea in mind. So, anyway, this is based on Augustus sub-study, where there was a benefit in Augustus. Triple therapy for 1 month reduced ischemic event on the landmark analysis. There was a reduction of MI by 0.9% if you use triple therapy for 1 month compared to only double therapy. There was a similar increase in bleeding of 0.9%. Overall neutral, but that allows you to kind of, decide based on the ischemic and bleeding risk whether you need to keep it for 1 month or not. At least it allows you to do that. In all cases, at 1 year, you should stop, and that's one thing we don't practice often. We should stop both aspirin and Plavix. So, okay, you gave at 1 month or at 1 or 3 days, you stopped aspirin. Between 3 days and 1 year, you gave double therapy, Eliquis and Plavix. Well, at 1 year, you should stop the Plavix. You only keep Eliquis. None of us does that, I know, or very few of us do. But this is actually recommended in those guidelines systematically, class 1. And it has been proven by one trial called AFIRE trial, which used rivaroxaban. And actually, rivaroxaban plus Plavix versus rivaroxaban only more than a year after a stent was associated with increased mortality. So rivaroxaban only had lower mortality. Okay. So that's the default strategy. Another thing is all those trials mainly included Plavix. All those 5 trials, 4 of them included about 5% of Ticagrelor. No prasugrel, maybe 1% prasugrel. So the idea is when you do triple therapy or double therapy with an anticoagulant, do not use prasugrel 100%. Rarely you can use Ticagrelor, but it's not favored. and you have to weigh carefully your bleeding risk. So, but it should be very rare to use Ticagrelor, okay? And if you do use it, consider switching at 1 month to Plavix, okay? So that's basically here. I think just have one slide. I might as well go over it. This is my last slide here. It's another topic, which is again Clopidogrel response testing. There are two ways of testing it, whether using platelet reactivity testing or using genetic testing. We have at our institution platelet reactivity testing in the lab. We don't have the point of care platelet reactivity testing, which is the better and easier way. But anyway, it has not been shown to be useful in the stable CAD setting. Even if you're resistant to Plavix, it doesn't mean you should upgrade. It showed no benefit in the peri-PCI trial. Upgrading to prasugrel if you're Plavix resistant showed no benefit. That's one. Two, in ACS PCI, as I mentioned earlier, it makes sense if you're resistant to upgrade because you have higher risk of events. But Taylor PCI genetic trial did not show that. So it's still questionable, even in ACS, whether you need to test platelet reactivity. The only place where it has shown benefit is deciding to de-escalate from Ticagrelor or prasugrel to Plavix based on the genetic and platelet reactivity testing. Basically, if you're not resistant to Plavix, then you can feel more comfortable breaking those guidelines and giving the patient Plavix after stent for ACS. So it's very valuable and make you feel comfortable in de-escalating and downgrading from Ticagrelor to prasugrel to Clopidogrel in the ACS setting, based on those two trials published also in the last year. All right, I think I'm done here. I know there's a lot of data. I know you have to go, but if somebody has questions, I'm available to stay. Those who wants to ask any question.
Hi, Dr. Hanna.
Yes.
Derek here. That was a wonderful talk. I have a question, and I guess I wanted to hear your thoughts on a practice that maybe I saw more of last. I haven't really seen much of it as a second year, but I did see maybe 2 cases that I remember. Patients coming in post ACS within 3 months on DAP, where they got stents placed. And then they were going for surgery that was, I wouldn't call them emergencies, maybe semi-emergent settings. And then what are your thoughts on the recommendation on using Cangrelor in place of the P2Y12 perioperatively? Because I remember the surgical team was kind of wary of bleeding complications. What are your thoughts on that?
So here there are several ideas. If you go by guidelines, and I think this came as an interventional board question, the minimal duration for which you will allow the surgeon to stop the Plavix is a 3 month. Okay, so even if you had DS for ACS, even for ACS, you allow the surgeon to interrupt Plavix after 3 months. Okay, it's been shown that interruption beyond that time frame for less than 10 days is safe. Most of your stent thrombosis events, when they happen after 1 month or more after your stent, will happen beyond 10 days of interruption. Okay, so that's an important idea to keep in mind. That said, the guidelines mandate 3 months. So you mentioned this patient was less than 3 months. So there are several ways of doing it. One way is to realize, based on the studies that I mentioned, that there is okay data suggesting that beyond 1 month, it's fairly safe to, at least if you don't want to stop it, interrupt the Clopidogrel. So one way to do it is to allow the surgeon to interrupt it without any bridging, based on the data, especially the one that compare bare metal to drug-eluting stent, 1 month of that. And the idea that it takes probably 10 days to get stent thrombosis. Most stent thrombosis events occur beyond 10 days. So one reasonable and probably the best strategy in that case, who needs a semi-urgent surgery, is to just interrupt Plavix and do nothing else. Okay. Second strategy is to ask the surgeon how comfortable he is to operate under dual antiplatelet therapy. Surgeons are becoming more comfortable, and depends on which surgery. So that's another consideration. You run the risk definitely of increasing the transfusion rate after surgery, but that's something to consider. Doing cabbage under Plavix, by the way, does not increase death. It increases major bleeding and requirement for transfusion by 4% in absolute, but it does not increase death, even operating cabbage with Plavix. And that kind of extends to other surgeries. So that could be a consideration. That's the second consideration. The third consideration is Cangrelor. I will tell you, I'm not a fan of that for several reasons. One, it's unproven. There is no randomized evidence for it. Two, when will you start Cangrelor? I mean, you stop the Plavix. Plavix is hanging around in your blood for about, or the effect of it is hanging in your platelet for about 5 days. When do you start Cangrelor? Do you start at 2 days, 3 days? Not very clear. The other thing is that, let's say you started probably at 2 days later. Okay, you'll have to stop it before surgery. And remember that most of your events don't happen before surgery. They happen in that during or immediately after surgery. Well, you're not going to give Cangrelor immediately after surgery. Most of your event, when you're stopping antiplatelet before surgery, happen in that nadir antiplatelet effect, which happens to be during surgery or early after, especially with the stress of inflammation and catecholamines. So really, when you're doing that strategy with Cangrelor, you're not giving Cangrelor at the time of highest risk. And that's why I'm not a big fan of it, because surgeon is not going to let you start Cangrelor within 24 hours. So, I mean, what are you achieving with Cangrelor? Bottom line, I'm not a big fan of it. I think it complicates things and it doesn't work. Similar ideas were applied with glycoprotein 2B3A in the past. I'm not aware of any data showing benefit, and there is always this bleeding hazard with it. So I hope that answers your question.
It does. Thank you so much.
Yeah, thank you. Anybody else has any questions?
Dr. Hanna, I had one quick question. Thanks for an awesome talk. For patients who meet the criteria for a prolonged DAPT more than 12 months, how long do you continue DAPT? 18 months or more than that?
Good. The idea of the DAPT trial went up to 2.5 years, which is 30 months. But the idea of long-term DAPT is what it is, long-term. You keep re-evaluating. But the idea is to go beyond the 12 months. If you want to go like DAPT trial, it's 30 months. But the idea of DAPT trial was not really to limit it to 30 months. It was limiting it to 30 months to do their analysis. But the idea of it is that you keep it as long as the patient is not experiencing bleeding side effects. That's kind of the idea, or as long as his bleeding risk has not evolved or changed. Same as it is, by the way, the idea with long-term anticoagulation after PE. The idea, they tell you, well, in those idiopathic PE or patient with procoagulant risk factors, the recommendation is over 3 months. They don't tell you how long. The idea is that it's a continual evaluation. You keep it on and you reassess the patient on your follow-ups. You try to keep it for as long as he's not bleeding or he's not having an evolving risk of bleeding. Okay. You can say lifelong, but it's not appropriate. You do your reevaluation every 6 months on your clinic visits. I answered your question?
Yes.
Okay. Any other questions?
Thank you, Dr. Hanna. This was great. So I guess we need to do one more for valves and Watchman and all those things.
Yeah.
So this was really great.
Yeah, sure. All right. If no more questions, thank you everybody for attending.
Thank you so much.
Okay, thank you.